For the three doctors that are presenting today, we've pushed all of them out of their normal presentations to develop presentations that are not their canned presentation, just like Dr. Harmatz mentioned. In a moment, Dr. Muenzer is going to present, and it's not his canned presentation either, and following with Dr. Dixon as well. So it is now my pleasure to introduce Dr. Joe Muenzer, MD, Ph.D. He's the Bryson Distinguished Professor in Pediatric Genetics and a professor in the Department of Pediatrics at the University of North Carolina at Chapel Hill. He's also the director of the recently created Joe Muenzer MPS Research and Treatment Center at the University of North Carolina at Chapel Hill, an academic-based MPS center designed to improve the lives of MPS individuals and their families. We're also excited about that new center and the good work that it has started doing. He's involved in the diagnosis, management, and treatment of patients with inborn errors of metabolisms, especially MPS 1 and 2, and the newborn screening for MPS 1 and 2. He's been a PI for more than 20 MPS clinical trials, just like Dr. Harmatz, done lots of them. He is currently the PI for a phase 1-2 gene editing clinical trial for MPS 2, and a phase 1-2 and phase 2-3 IV-ERT clinical trial to treat brain disease in MPS 2. Just like Dr. Harmatz, I've had the pleasure of him treating my children as well for many years, and we've been blessed with his doing that. He, as well as Dr. Harmatz, also serves on the Scientific Advisory Board for the National MPS Society for many years. He's going to be presenting on Unified Horizons, where research, unmet needs, yes? Oh, it's been changed. The clinical and research, yes, future opportunities and challenges. Take it away, Dr. Muenzer.
Thank you. It's my pleasure to sort of present here. One, I want to congratulate Paul for his award, well earned and deserved. He's done a lot for the field, as he appreciated, 25 years ago? When did you see your first patient, Paul? So it's been a long time, but it's really been a pleasure to be involved with him. He made the comment early on, historically, we would talk at different meetings about MPS 1, MPS 2, and MPS 6. And I would always talk about 2, and he would talk about 6, and he always had to put up with us talking ahead of him, but he's certainly been a pleasure to work with him over the years. What do you need, Steve?
An issue with the clicker, possibly. Is the clicker working?
It just worked. It just worked, Steve.
They're telling me different? Okay.
Well,
all right, let's go.
So those are my disclosures you already heard. I serve on a variety of advisory boards and consult for biotech companies, and you heard the different trials I'm currently involved with. So what I want to do is really sort of talk about the current status very briefly of MPSs, the recently submitted BLAs, so-called biological license applications, and I'll explain more about that in a little bit. Talk about then biomarkers and the FDA accelerated approval pathway. Ongoing and planned MPS clinical trials. These are not all, but just some of the gaps that we have in MPS treatment. And then time should allow to talk about newborn screening. And if you could set the clock up here so I sort of know where I am, please. Thank you. So as we all appreciate, the MPSs are a group of lysosomal storage disorders. There's now 12 known enzyme deficiencies, 8 different types. As an aggregate, if you take all the MPSs together, I estimate a 1 in 25,000, maybe 1 in 20,000, but still very rare. The hallmark of the MPSs, as most of you appreciate, is the storage of these complex sugars called glycosaminoglycans. These are progressive disorders, unfortunately, and as you saw from the MPS 6 individual, it really can affect the whole body. And there's a wide range of clinical involvement in each MPS disorder. And Paul described very nicely what we see in MPS 6 in terms of the different sort of forms of it. Again, these disorders are all due to the deficiency of an enzyme involved in the breakdown of different types of GAGs. This is for MPS 1, just showing ironidase in terms of schematic for dermatan sulfate. The glycemic glycans are complex molecules, but in summary, they're really repeating sugars, a so-called disaccharide, two sugars together, and they repeat. And that's a unique feature that will come back when I talk a little bit about some of the GAG analysis. What's not happening is the slides up here are not advancing on the computer, but I'll go off this. So again, in terms of an overview again, MPS 1, 2, and 7 all have physical or multisystemic involvement and can have CNS involvement, but never only have CNS disease. So all have physical disease, and some, or sometimes more than some, majority have neurological involvement. In contrast, Sanfilippo, or MPS 3, is a primary neurologic disorder with cognitive impairment. And the mild forms we probably miss because of the challenges associated with diagnosing somebody with just a developmental delay. MPS 6, as you already heard, has lots of physical involvement, but never have primary intellectual involvement. Thank you. And then MPS 7, something called non-immune hydrop fatalis, where there's sort of inflammation in utero occurs, and that's the common presentation of MPS 7 in the US, a very rare disorder, but in other parts of the world, we see more like MPS 1 presentations. We have two current treatments that people tend to use: hematopoietic stem cell transplantation and intravenous enzyme replacement therapy. And this just shows you my view of the world in terms of treatment options. As Steve alluded to, when he first got involved, all I used to do at this meeting is talk about management, how to deal with complex problems, not talking about treatment. So it's just, for me, it's a phenomenal pleasure just to be able to say we have options. As you already heard, there's still a long ways to go, but we have options. Transplantation is primarily for the severe form of MPS 1 or Hurler syndrome. It's the treatment of choice. Transplantation historically was used in MPS 6 prior to enzyme therapy, but now there's really no need for that because of transplantation. There's a minimum of 5 to 10% mortality in the best transplant centers, and so IV therapy, IV enzyme replacement therapy just doesn't have that risk. So there's really, in reality, unless enzyme is not available, one should never consider transplantation for 6. In terms of MPS 2, 3A, and 3B, it's really been challenging. These patients tend to present a little older, more neurologically involved when they present, and so right now it's still up in the air. There's some patients with MPS 2 who have been transplanted very young, and they may actually do much better with modern transplantation technologies. As you already heard from Paul, there's actually 5 different enzymes available: 1, 2, 4A, 6, and 7. But what are the limitations? Yes, we have treatments, but what are the limitations? IV enzyme typically is weekly treatments, expensive, and unfortunately, IV enzyme does not treat the patients who have brain disease because the enzymes are large glycoproteins and they don't cross into the brain, cross the so-called blood-brain barrier. There's many somatic tissues and clinical features that are not typically respond to either IV enzyme or transplantation. Transplantation gives some enzyme, but it really not enough. And I'll show you some upcoming data that where if you put a lot more enzyme into a patient, you may do much better. Synovium, the lining of the joints. Trachea in MPS 2 and 4A. The bone disease in general is not impacted. Corneal clouding. And then carpal tunnel syndrome, which occurs in a number of disorders, also was really not impacted. These are relatively avascular tissues, and the enzyme just doesn't get into those tissues in the amount we give. I already alluded to, we have no effective treatment option for the brain disease in MPS, except for Hurler syndrome, where transplantation early on can stabilize their function. Let's talk about now some of the challenges. I refer to the term neuronopathic MPS, that is individuals with MPS who will develop cognitive impairment. The clinically diagnosed MPS patient with developmental delays, cognitive impairment, unfortunately already has significant impaired neuronal function that I believe is typically irreversible. And I'll talk about later in the talk, as time allows, to talk about newborn screening and how that may impact. Replacement of the missing MPS enzyme in the brain of a neuronopathic individual with cognitive impairment will not result in cognitive improvement, but at best clinical stability. And that's one of the messages that we need to treat early, because otherwise we won't get benefit. Placebo-controlled clinical trials of greater than 1 or 2 years, which is what the FDA really wants companies to do until recently, for a progressive, irreversible neuronopathic MPS disorder, to me is unethical. Companies have been forced to do this because they have no choice. But again, society and other patient advocate groups need to push the FDA to say, we have another way, and I'll talk about that in terms of accelerated approval and using biomarkers. So what's a BLA? You've heard that term, and it's right there, a biologics license application. It's the application to the FDA to get a drug approved. It's an incredibly large document that contains detailed information of manufacturing, chemistry, pharmacology, and the clinical data. Prior to electronic submissions available, this could actually be half a pickup truck, half a van, I should say. Incredible number of boxes, so lots of detailed information. Again, if the FDA finds the application acceptable, it will approve the BLA and issue a license, allowing the applicant, that is the biotech company or sponsors, to market the product. So that's how drugs get approved in the US. What's unique about the BLA, and why do I talk about it? Because to me, a unique time that there's been actually 3 recent BLA applications submitted. I want to spend some of the next 5 or 10 minutes just talking about those and how they came to be. So Ultragenyx announced early this year that the FDA accepted and given priority review, that is 6 months review, of their BLA for UX111, an IV AAV9 gene therapy for Sanfilippo A. The FDA decision was expected by August 18th of this month, so-called their PDUFA date. Let's just go back a second. So Abeona company initially developed the IV therapy the IV gene therapy for 3A. Unfortunately, they went out of business because of just lack of financial resources. Ultragenyx, and it's really Emil Kakkis, is really sort of did this, saved this treatment, obtained the rights in 2022. At the highest dose they used, they saw a reduction of CSF heparan sulfate of about 50%. And that's important because heparan sulfate is a glycosamine glycan that is stored in the brain of Sanfilippo patients and all the neuronopathic patients, that is MPS 1 and 2 patients and 7 patients. They have clinical data showing that the Bayley, a test of developmental abilities, the Bayley cognitive raw scores showed a positive rate of change indicating either stability or gain from baseline in the 16 of the 17 patients during the expected window of plateau into decline. So again, as you probably appreciate, the MPS patients are normal at birth. Their development as Sanfilippo patients slow down, plateau off, and then regress. And so this is the time where they're sort of plateauing or regressing, and these patients now are stabilized. So they really change the developmental trajectory. Unfortunately, just last month in July, 11th, the FDA issued a complete response letter for UX111. Normally, this letter says the drug is approved, but this basically says it's not approved. There's cited concerns about the manufacturing processes and the facility observations. Unfortunately, Ultragenics have or fortunately, these are most likely all addressable and are not related to the product or the clinical trial data. It's really how the drug is made. Unfortunately, once these issues are resolved with the FDA, they have to refile their BLA. And in theory, the FDA could take another 6 months after refiling to accept it or make another decision about it. They don't accept it. So that's really unfortunate, because I was really hoping that we're on the cusp of having a treatment for Sanfilippo A, this month. Hopefully we'll have good news at the next meeting that this drug has been approved. So another BLA was submitted by REGENXBIO for their product RGX-121. This is for intrathecal gene therapy for Hunter syndrome. They're using a biomarker called CSF-D2S6. This is a unique disaccharide. It's a very prominent disaccharide. If you take heparin sulfate and digest it, you get a lot of this D2S6. And they're using that particular disaccharide under the accelerated approval pathway to hopefully get their drug approved. Their target date for the FDA to say something is November 9th, 2025. The typical response is the FDA waits till the final day, sometimes even the afternoon of the final day, before they'll issue their response. With all the changes in the DC and the FDA these days, it's unclear what's going to happen to this, but I'm hopefully optimistic that we'll see a gene therapy approval for MPS II. And I'll just sort of go back again and just talk a little bit about this trial. So RGX-121 has been well tolerated in 25 patients enrolled as of January 2024. 3 doses were evaluated. They had to use immune suppression for 48 weeks with prednisone, tacrolimus, and sirolimus, because in their animal studies, they saw some toxicity in the spinal cord area. Data from the pivotal dose level has demonstrated a sustained reduction of CSF heparin sulfate as a D2S6 to approximately 85%. So a dramatic decrease in this toxic molecule that causes the progressive disease in Sanfilippo A. So this actually shows their data from a couple of years ago. Different doses showing a dose response effect in terms of lowering CSF heparin sulfate disaccharide, and here's their individual data. So 80% of patients, unfortunately or fortunately, in the pivotal dose could discontinue their IV ERT or remain treatment naive, but 20% still had to stay on treatment. Subjects with cognitive function below -2 standard deviations at baseline didn't really change at all. So if you're already significantly neurologically impaired, the drug stabilizes, but it doesn't make them any better whatsoever. Subjects with cognitive function above this -2 standard deviation baseline typically remain within that. So they're actually gaining skills at the last assessment. So that's encouraging. So it'll be interesting. Hopefully we'll get a very positive response from the FDA for RGX-211, and we'll get a treatment for the brain disease for MPS II and intrathecal gene therapy, where they put the AAV vector into the spinal fluid at the base of the neck, or they could put it into the ventricle. So the other BLA application that's pending at the FDA is for Denali Therapeutics for their product DNL310. They refer to it as TIVI, under the accelerated approval pathway. Again, I'll come back to that in a little bit. This case using CSF heparin sulfate, that is the total heparin sulfate, as their biomarker. In this case, it's an IV enzyme that's been designed to penetrate the brain for Hunter syndrome, and I'll talk about that. And their PDUFA date, their date that the FDA has to let the company know, is January 5th. And that should be 2026, not 2025. It's my typo. So what is this product? What is DNL310? So it's the recombinant protein, or fusion protein, that takes the MPS 2 enzyme, iduronate 2 sulfatase, and it's fused to an immunoglobulin fragment that recognizes, that binds to the transferrin receptor. So it's basically a molecule that's designed to bind to the transferrin receptor. I should say the transferrin receptor is ubiquitous in the body because our cells all need iron, and the transferrin receptor's normal function is to take iron inside the cells. So you can see here a schematic, in this case, molecule of enzyme, iduronate 2 sulfatase, has been fused to a fragment of an immunoglobulin that recognizes, in this case, the transferrin receptor in this schematic view. So for today, I think it's actually 47, but I have here 45 patients with MPS 2 has recently received weekly IV infusions of DNL310 with a dose ranging from 3 milligrams to 30 milligrams. I want to point out that this molecule, DNL310, is roughly half enzyme and half fragment. So a dose, of dose of this molecule only is half enzyme, and I'll come back to that in a second. So DNL310 was safe, but the infusion reactions we've seen were more than observed with Elaprase, that is, infusion reactions. But they saw rapid normalization or near normalization of CSF heparan sulfate occurred in all study subjects. So what that means we know from animal data, if you normalize CSF heparan sulfate, you have to normalize brain tissue heparan sulfate. And the brain tissue heparan sulfate is the toxic metabolite. So if you get rid of that, then we shouldn't see any more deterioration in terms of the brain disease. Not guaranteed to get improvement, but no deterioration. The key is when you start, earlier the better, you can appreciate with that statement. This shows that dramatic reduction we see in heparan sulfate, basically is normal or near normal levels. So both clinical and caregiver global impression scales of change suggest majority of patients stabilize or improve across all domains at the 49-week baseline compared to baseline in their open label study. Denali was basically pushed a couple of years ago by the FDA to enroll a phase 2/3 that's placebo-controlled for 2 years of weekly enzyme at a dose of 15 milligrams per kilo of DNL310, equivalent to basically 7.5 milligrams per kilo of enzyme, which is 15 times the current Elaprase dose. So that's the 3 BLAs. And so there's really optimism that hopefully by early next year, we'll see approval of 2 treatments for MPS 2, and hopefully sometime in 2026, a treatment for the brain disease for Sanfilippo A. But that hinges on this concept of accelerated approval pathway. How many in the audience have ever heard of the accelerated approval pathway? A few. So traditional drugs approval typically requires well-controlled clinical trials. And I should say that this well-controlled clinical trial, that S, there's been Ph.D. theses written on what does that S mean? Is it 1 trial? Is it 2 trials? So it's one of those challenges. The accelerated approval pathway allows for drugs with serious conditions like the MPSs, with unmet medical need, that we have no really treatment for the brain disease for most of the MPSs, to be approved before demonstrating clear-cut clinical benefit. And the accelerated approval offers this early access to treatment, but the sponsor is required to perform post-marketing confirmatory trials that demonstrate actual clinical improvement. And the rationale being is that the approval based on the surrogate endpoint that's reasonably likely to predict clinical benefit. And to me, there's very good data supporting that if you decrease, and I'll talk about more, decrease heparin sulfate in the spinal fluid, you're decreasing heparin sulfate comparably in the brain tissue itself. So let's talk more about this. So why should CSF heparin sulfate be a biomarker for accelerated approval in neuronopathic MPS? The enzymes involved in the MPSs are only active within the lysosome. They don't work in the bloodstream. Heparin sulfate, as I alluded to, is the primary substrate that accumulates in neuronopathic MPS individuals. CSF heparin sulfate levels correlate with brain tissue heparin sulfate in the MPS animal. As you all appreciate, we can't be doing brain biopsies on our MPS patients, so we have to use the animal studies. But the animal data is very convincing in lots of different animals, animal studies. More importantly, CSF is a dynamic fluid. It turns over. It changes. And so again, if you see a change, that has to reflect, an active process. The only way for CSF heparin sulfate to be decreased is if the enzyme enters brain tissues and reduces brain heparin sulfate content. Otherwise, this heparin sulfate leaks out of these brain tissues or gets removed, it comes out of heparin sulfate. It's reasonably likely to predict clinical benefit. So this is the basis of certainly the last two BLAs in terms of Denali and REGENXBIO. They're basically allowing to get approval, not on overwhelming clinical data, but on dramatic reduction of CSF heparin sulfate. Over a year ago, I was at a meeting at the Reagan-Udall Foundation, which is a foundation to support the FDA. And part of my presentation, I had these 10 reasons why the biomarker CSF heparin sulfate should be utilizing accelerated approval pathways should be utilized for neuronopathic MPS. Let's just briefly, some of these are already obvious, but I'll go over them again. Neuronopathic MPS are ultra-rare disorders. There's no more than 500 MPS 2 and 3A patients in the US. We understand the biochemistry for a long time. The primary event of this disorder is the defect in GAG metabolism that results in interlysomal accumulation of heparin sulfate due to deficient enzyme. Heparin sulfate is always elevated in the neuronopathic MPS individuals. We can now readily measure CSF heparin sulfate. And again, in animal data, heparin sulfate correlates with brain tissue. CSF heparin sulfate correlates with brain tissues. Reduction of CSF heparin sulfate reflects reduction in brain tissue. Reduction of secondary disease activity biomarkers of lysosomal dysfunction. I won't spend a lot of time on GM2, GM3 basically accumulate secondary to the primary defect. And then there's a marker of neuronal injury, neurofilament light chain, NFL, also supports the relevance of CSF heparin sulfate as a biomarker. Reliance on the clinical efficiency with placebo-controlled clinical trials to demonstrate effectiveness is really, to me, unethical. Because again, these patients have the MPS patients who are neurologically involved have irreversible brain disease. We can stabilize, but we can't make them better. And again, regulatory flexibility is needed now to bring treatment to the individuals with neuronopathic MPS using the FDA 2020 industry guidelines. So there's guidelines that are written. It's only with this Reagan-Udall Foundation meeting and then supplement that the FDA was willing to consider. Prior to 2 years ago, they absolutely said no to using biomarkers in the accelerated approval pathway, even though they have their own guidelines, saying that we could do it. Change pace. What's ongoing planned MPS clinical trials? There's some other brain penetrant enzyme trials out there, gene therapy, anti-inflammatory. In the previous talk, Paul alluded to the in utero ERT, and I won't talk any more about that. There's a clinical trial going on with high-dose oral Ambroxo for MPS 3 adults. This is basically a molecular chaperone. So what's the molecular chaperone? Most of you at some point in your life had chaperones, but you haven't had molecular chaperones. What a molecular chaperone is the proteins are made in the body as long linear chains, and then they have to fold properly. And so a chaperone helps that folding occur. And a lot of the defects we see in the MPS population is due to misfolded protein. So potentially a molecular chaperone could help. So that's a trial that's going on. I won't talk anymore. And then maybe afterwards, Paul could just comment where he is in the orthotamide trial for MPS 4A and 6, which is basically try to improve growth. And maybe you could just comment that where you are, Paul, in that status. I won't talk. So let's go now to brain penetrant enzyme. You already heard a little bit about it. Just shows you that blood-brain barrier schematically that we need to get across from IV infusions. Again, if you put an enzyme directly into the spinal fluid, just note you're inside the blood-brain barrier already. So again, JCR is developing a product for MPS 2, 141, that's similar to the Denali product, but different. They have 2 molecules of enzyme hooked to an immunoglobulin molecule that basically binds to the human transferrin receptors throughout the body. Similar to the Denali product, JCR product has half basically enzyme and half immunoglobulin. So effectively, any dose of JR141, half of that is actual enzyme dose to compare to Elaprase. This drug is actually approved in Japan in May of 2021. And you can see over on the far left side showing CSF heparin sulfate, and it has come down. But again, it's still 70–80% reduced, but it's still not normalized. And shows in clinical outcome was a benefit. Look at over a 1-year trial, patients who were attenuated who got this drug, they're going to stay that way. They're not going to have neurologic disease. Patients who were very early on in the phase, they appear to have benefits similar to the attenuation, but patients who were much more involved with Hunter syndrome, either middle or late phase that they describe in Japan, had no benefit. And just showing you that no benefit doesn't mean the enzyme didn't get into the brain. It means that there's irreversible disease, and the best they can hope for is stabilization. So JCR has started a 2-year global phase 3 study, has 2 milligrams per kilo IV weekly, compared to idursulfase, a 0.5 milligram per kilo IV weekly in February of 2022, and they're close to being, if not fully enrolled. In this case, they're assessed, they're blinded, that if you were getting Elaprase, you could get that at home. If you got the JCR product, you had to get that in the clinic setting. So Denali has an ongoing phase 1/2 study that I already alluded, a phase 2/3 study ongoing. What I realized this morning, I didn't put up that both JCR and Denali has similar clinical trials for Sanfilippo A that are in the phase 1/2. So there's trials going on similar to that. That's still, number of years away before they're ready to submit a BLA. But again, so there's lots of happening in the Sanfilippo community, whereas most people in the Sanfilippo community 3 or 4 years ago, there was absolutely nothing for a long time. And people used to say when IV enzyme got approved for all the 5 drugs, Sanfilippo families say, why not us? Well, your time is coming, but hopefully it's coming sooner than later. So gene therapy. So what's gene therapy? I'll just briefly describe it as a procedure in which DNA, or genetic material, for the deficient enzyme is inserted into an MPS cell to correct the enzyme defect, basically putting back a normal copy of the DNA that the patient doesn't have correct version of. Again, the body now can make the enzyme, where in contrast, IV enzyme therapy, that drug is made recombinantly in factories. The idea here for gene therapy is the drug is made in the body like we all ourselves can make it. Typically, modified viruses are being used to deliver the genetic material, but there's one caveat in terms of Immunosoft, and I'll talk about that since they're using not a virus. two ways to do gene therapy in general. Ex vivo, take cells out of the body, transfect them with the vector. Hope that will now, those cells will now be overexpressing enzyme and give them back, or directly give, in this case, AAV for the MPS to the patient, let the virus go into a cell, deliver the genetic material, and therefore now hopefully make enzymes. Lots of preclinical studies in animals in the last decade. There's at least 20 human MPS gene therapy trials that have been completed or are in progress, unfortunately with no approved product. And I was really hoping that we could say in a few weeks that we'd have the first approved gene therapy for MPS in Sanfilippo, but that's not the case. I could spend the next 3 hours talking about the different gene therapy slides going on, but I'll spare you and do it in about 5 or 10 minutes because Terry will never let me come back again if I do that. So in terms of MPS 1, I'll spend a little more time after the sort of overview of ex vivo gene therapy for MPS 1. I'll talk a little about IV modified B cells Immunosoft is doing. You've already heard in terms of Regenexx Bio, the ex vivo, the intrathecal AAV9 that I talked about the BLA, and then hopefully in Chapel Hill at UNC, some point in the next couple of years, we'll do intracorneal injections for MPS 1, basically putting a little AAV vector into the cornea, and basically it just, in the animal MPS 1 dogs, the corneas become clear within a few weeks. So it's dramatic response instead of having new corneal transplants. In terms of MPS 2, intrathecal AAV9 talked about. European study is doing intrathecal AAV9 in Spain. And then there's been a single patient now enrolled in an ex vivo MPS 2 lentiviral study at the University of Manchester. That study has been challenging to recruit. Initially, their age requirement were I think 4 to 12 months of age. And they couldn't recruit those patients, so they've now raised it to 3 or 4 months to 22 months. And they've now dosed their first patient at Manchester with ex vivo gene therapy. And I'll show you in a little bit just what happens with ex vivo gene therapy for MPS 1. In terms of MPS 3A, the Spanish company is also doing intrathecal AAV9. University of Manchester has treated 5 patients with ex vivo gene therapy for Sanfilippo A, and 4 of the 5 have done dramatically well. It's unclear why the 5th one didn't do quite as well, but it's still altered. And then you already heard about this IV AAV9 gene therapy that now Ultragenyx is trying to get approved. For patients with more there's hopefully will be in the next year to 2 years an Intervius AAV8 gene therapy trial that will happen to try to go after hopefully the bone disease. So I want to just talk about this ex vivo gene therapy for MPS 1 that's been published for a couple of years now, but showing the possibility of this technology. There are 8 subjects with Hurler syndrome who lacked a suitable donor and who still had normal cognitive abilities, a DQ developmental quotient of greater than 70. Ex vivo gene therapy using lentivirus, and they had this case a couple of years ago, follow-up of almost 4 years. What they found is they got super physiological levels of enzyme in their bloodstream. So what does that mean? If we take everyone in the audience and measure their enzyme in the blood, we can come up with an average. The MPS 1 patient typically has less than 2% of those normal levels of enzyme in their blood. In this case, the product resulted in 5 to 7-fold increase of enzyme above normal. So just dramatic increases compared to what we normally see. They had stable cognition, improved growth, and normalization of joint mobility. You know, I've said that maybe we can't reverse it, but the message may be if we give enough enzyme, maybe we can reverse things if we're early enough. They had improved or stable findings on MRI of the brain and spine. clinical functional and radiological measurements suggested an early benefit. And again, the MPS1 ex vivo gene therapy provided superior metabolic correction in Hurler syndrome compared to the standard transplant. So this is much better than the standard transplant. So a phase 2/3 ex vivo gene therapy using the same antivirus has completed enrollment of Hurler patients in the spring of this year in both Europe and the US. It's a 2-year randomized study to either ex vivo gene therapy or standard transplantation. It's an open label study. And one of the important things is that normal transplantation, there's a risk of at least 5 to 10 or greater percent mortality in the first year after transplantation. In this case, they're using the patient's own cells, taking them out, transfecting them and giving them back, and the mortality is probably 2 to 3%, so dramatically improvement in mortality, but a much more challenging procedure because you have to have a special lab to process these and handle and then give them back to the patients. So allogeneic transplant is much more risky than autologous transplant. B cells. We all have B cells. They're part of our immune system. They're capable of secreting protein because that's what they do. They secrete antibodies in response to infections. So a company called Immunosoft has developed an ex vivo, taking cells out, B cells out, using a so-called Sleepy Beauty transposon system, a non-viral gene therapy. To date, 2 adults with MPS1 have been dosed. One of those at least been dosed a second time, since you can repeat the dose. And they hope to do MPS2 patients in the near future. So in summary, the initial clinical data demonstrating reduction in GAGs and early evidence of clinical benefit in younger patients. The results from the phase 1/2 MPS1 ex vivo gene therapy are really encouraging in my mind. Potentially, we can maybe reverse some things. The 2-year phase 3 clinical trials completed enrollment of patients in US and Europe. And again, it very well be that gene therapy is going to be an emerging therapeutic strategy for the treatment of MPS disorder. Hopefully, we'll see that with Sanfilippo in the near future, but it still has lots of potential. So very briefly, anti-inflammatories, I'm running sort of late on time. Again, a drug has been evaluated, pentasan polysulfate. There's been 2 small studies, both in Japan and Germany, that suggest maybe a little benefit. There's been a larger trial in Australia with MPS1 patients with subcutaneous injections, showing there was decrease in GAG fragments, decreased cartilage degradation, biomarkers, decreased scores for pain interference. So some suggestion of improvement. It's very possible that in the future we'll see, say, ERT plus another adjunct therapy like this because of the immune system. The same way, there's been a phase 1/2 sub-Q anakinra. So anakinra is a medication that decreases IL-1, which is part of the inflammation that we see in patients, either in MPS3 or Sanfilippo patients, have been completed in the US. 7 patients had to withdraw due secondary to intolerance of the daily injections. As you Sanfilippo parents realize, this can be challenging when you have a developmentally delayed child to have to inject them not once, but twice a day. But they saw some promise. The hope is there will be a phase 2/3 trial, but it's challenging to fund that trial because of the cost of the anakinra and just the trial itself. So treatment gaps. We have no treatment for the brain disease and Hunter syndrome, Sanfilippo A, B, C, and D, and MPS 7. Although ERT is approved for Morquio syndrome, the bone disease is not significantly impacted by IV ERT. We have airway disease issues in MPS 2 and 4A that are difficult to recognize, and treatment is challenging. A better understanding and improved management of the disruptive behaviors in individuals with MPS 2 and 3 is really needed. Newborn screening is needed to identify MPS individuals prior to the onset of significant disease to improve outcomes. We can do much better preventing than we can correcting. So my last few minutes, why newborn screening for MPS? They're ultra-rare disorders. I estimate there's less than 2,500 MPS patients in the US. Each MPS 1, 2, and 3A I estimate there's less than 500 patients. In general, MPS patients appear normal at birth and subsequently develop somatic or cognitive impairment. The exception is the exception is the MPS 7 patients with non-immune hydrops. In the US, I estimate the average pediatrician sees 1 or 2 MPS patients in a lifetime that they've recognized. That's the challenge. So why newborn screening? Clearly, we know that storage starts in utero. We know that the neuropathic patients can develop initially normal for a few years, but then have regression and regress. The clinically diagnosed patients with developmental delay, cognitive impairment, again, already have neuronal function that's most likely irreversible. It's important to hear that because it's just, we need to treat them earlier and earlier to get the best outcome. Most families, if you take a poll, would find that here too, the diagnostic odyssey, that is the time the family becomes concerned to when the diagnosis is made, is easily greater than 1 to 2 years, and sometimes it can be 4, 5, or 6 years. IV enzyme is available to treat the somatic disease, but doesn't prevent the neurologic problem. And more importantly, we now have the methodology to do newborn screening for the MPS disorders, where we didn't have that 4, 5, 6 years ago. MPS 1 now is approved for newborn screening by the so-called RUSP, the Recommended Uniform Screening Panel. Won't go through the rationale, but there's clearly lots of rationale to pick up patients before they become symptomatic. So again, MPS 1 was added to this Recommended Uniform Screening Panel in February of 2015. I estimate that greater than 95% of the current US population is being screened for MPS 1 now that Texas has started newborn screening for MPS 1 in the last month or two. So the vast majority, we're going to see a different population in 5 or 10 years since we're going to be identifying patients much earlier, picking them up and treating them much more appropriately. MPS 2 was added to the RUSP in 2022. Uptake of MPS 2 hopefully will be much faster than MPS 1. I should point out that West Virginia is currently screening for Morchio or 4A. And there's a pilot study going on in New York area for MPS 2, 3B, 4A, 6, and 7 in selective hospitals. But the current challenge is this slide. Newborn screening in the US is a state-based public health program that is not funded by the federal government. Each state funds their own newborn screening list. The RUSP, the Recommended Uniform Screening Panel, is a list of the disorders that the US Secretary of Health and Human Services recommends for all newborns to be screened for part of their as part of their state's newborn screening program. Unfortunately, the federal committee, which is responsible for adding disorders to the RUSP, has been disbanded in April of this year by the Trump administration. It's unclear the path forward, how we're going to be able to add other MPSs to the RUSP, or how states are going to have to do it themselves. Thank you for your attention. There's time for questions,
Yes,
Steve?
thank you, Dr. Muenzer. So we do have time for some questions. Dr. Muenzer's covered a lot of ground through this presentation.
But he asked me to cover a lot of ground.
I know it. I know it. You did what you were asked to do. Yes, here we go.
Hi, Dr. Muenzer. Just a quick question.
I encourage you to introduce who you are, everybody.
all right.
Ask the question, not just you, Scott.
Scott Loythers, new CSO of the National MPS Society. So with the Denali 310 product, I don't know if you know, but I'll ask, do you know if the immune responses that were seen to the product itself, were they targeting the transferrin receptor binding portion, or were they actually targeting the therapeutic enzyme portion?
I don't know the specific answer to that question, Scott.
It was just surprising that they had higher levels of response with their product. So that's why.
Mm-hmm.
Denali is here this weekend, so you can probably seek them out and find that out.
The people here won't be able to answer that question, Steve.
Except they're not here. But I bet they can get the answer for you, though.
Hi, Lisa Berry from Cincinnati Children's Hospital and board member. Similar question to Scott's actually for Denali's product MPS2. Do we think there's going to be any role for immune tolerance induction or ITI prior to starting ERT?
I think that's a challenging issue. We know there's more infusion reactions. I think depending, one possibility is to do actually a lower dose, not go at 15 per kilo initially, but start much lower and work up. That's sort of, probably not immune tolerance induction as we know, but there may be some patients need that. We're going to have to figure that out. As you appreciate, there are Elaprase patients who could really benefit from immune modulation. And we, even though there's, the brain's not impacted, but their physical disease can be slowly getting worse, unfortunately.
Other
you.
questions? You want to see me try to run?
No, Steve, we don't want to see you run.
Amy Fadden, mom of a San Filippo angel. What potential do you see for mRNA and gene editing in treating MPS disorders?
They're potential therapies, but they're clearly much farther in the distance. Again, that could be in the future another option, but I don't see those in the next 5 or 10 years. Even nobody, to my knowledge, is getting into those areas yet for MPSs. One of the challenges is the rarity of the MPS disorders. Things like hemoglobinopathy, there are just thousands of patients where we don't see that.
Yeah, hi, Ryan.
Can you answer that question?
Yeah, I maybe answer one or two, but I'm Ryan Watts from Denali. And I guess one question and then maybe a comment around immunogenicity and IRRs, I think, to answer some of the questions that were asked. But what do you think we as a community can do around this accelerated approval and the changes at the FDA? I'm just really curious, for you and for all of us, parents, but also, industry. What are you sensing right now, Dr. Muenzer?
Well, the challenging time is prior to January, with the previous administration, we thought we were in good shape. Yeah, and I was really surprised, in terms of what they did to Ultragenyx in terms of that. Yes, they potentially had some legitimate issues, but they could have worked through those. I'm still encouraged that the pathway is there. For rare disorders, the accelerated approval pathway is the only way to really go. We cannot ethically do long-term placebo-controlled trials. Even a 2-year placebo-controlled trial that Denali is currently running, we're sacrificing patients because their brain disease is continuing to deteriorate. And we can't reverse it. And that's the key point. If we could reverse it after 2 years, then it's different. But these are irreversible. And so I think it's more educating, as you appreciate better than most. There's a lot of turnover at the FDA. There's a lot of changes. A lot of them are really not very knowledgeable about these rare disorders. They deal with a lot of them. So it's both advocacy in terms of getting advocacy groups are pushing the FDA to do this, plus hopefully just educating them more. But again, it's a challenge.
Yeah. I agree with you completely. And maybe just one comment. So I guess answering both the original question. So the short answer is that the immunogenicity is to the enzyme, not to the FC. It's not immunogenic, so it's actually the enzyme. What's really fascinating, and I think Dr. Muenzer did a great job of highlighting this, our goal was to dose substantially higher. So the IRRs and these infusion-related reactions are related to dose. The higher you dose, the more IRRs. But what's fascinating, and you've shown the data many times before, Dr. Muenzer, is that those IRRs go down over time. And in other words, you build tolerance over time. And that's the ultimate goal. The reason you push dose is to really, try to, hit everything, the entire body, and including brain. And I think what we've learned is Elaprase, and you can comment on this, Dr. Muenzer, is substantially underdosed. Essentially all of our patients, when we measure their heparan sulfate levels in urine, even before starting the trial, there's not normalization with the standard dose that's given. And I think part of that is the field was dosing up to IRRs. They saw a response, but if you keep dosing higher and higher, even with Elaprase, my expectation is you would see more and more.
I would argue what happened. Early on, the dose was picked as much by what could be produced for clinical trials, not what was the optimal dose. And again, there was concern about, dosing. I can remember a meeting that occurred about 12, 13 years ago, where the proposal was to do 100 milligrams of interthecal enzyme for MPS II in the interthecal trial. And there are some people say, no, you can't give that much. It turned out we can give that much. It's safe, but historically there was that reluctance. Plus, the dose that picked for Elaprase, as you appreciate more than most, that was all they could make. They could only make enough enzyme to treat their 30 or 40 patients at that dose. They couldn't dose 5 times because they couldn't make it. Technology has come a long way. We can make enzyme better. It's still expensive, and especially with having the immunoglobulin fragment, you can pull out those enzymes so much more, and so your product is probably even cleaner than we had with Elaprase.
No, that's exactly right. I think it's cost of goods to manufacture. But my guess is if you were to dose more and more Elaprase, you would also see more and more IRRs. I mean, that of course you can't do that.
Absolutely agree with that.
Yeah.
We would see more reaction the more we give.
Yeah. But anyway, so it's really like, and then I guess the question on ITI, the goal is to build tolerance over time. ITI has its own set of, challenges, as you already highlighted, Dr. Muenzer. Yeah.
I think one of the unique things about the Denali product is that we've seen in the patients who are already on Elaprase, normalization or tolerance of their antibodies. So they actually tolerize. That hasn't happened as quickly with the native patients who were never on enzyme. But that important to me is another important factor, that there's unique properties of this FC fragment that we don't fully understand.